Okay, now we're going to talk about obstetric and neonatal transfusion, or as I like to call this talk, mamas and babies. So our main topics will be neonatal transfusions. What do we do different for neonates? HDN, neonatal alloimmune thrombocytopenia, and a few words on post-transfusion purpura. So the main thing I want to illustrate about normal neonates is it is normal to transition from hemoglobin F, right, with 2 alphas and 2 gammas, before birth and soon after birth, transition into hemoglobin A. So you go from mainly hemoglobin F to hemoglobin A. That is normal. And you got to think about these 2 different hemoglobins, right? It is also normal soon after birth to decrease your red cell count and to decrease your hemoglobin and hematocrit. That is normal. Why is that? It's normal because hemoglobin A has a better ability to deliver oxygen, right? Hemoglobin F has a higher affinity for oxygen, but less of an ability to deliver. So if you think about, you need to deliver a certain amount of oxygen, and if you have something that has a lower affinity and a higher ability to offload it, then you need fewer of those delivery vehicles to deliver that oxygen. Make sense? So this is normal. Don't be misled if somebody asks you, oh my God, in the first several weeks of life, the hemoglobin drops a few grams per deciliter. If the baby's okay, there's nothing to worry about other than reassure the family if they ask. But a decrease in hemoglobin the first few months of life is normal. If you look at the normal ranges of hemoglobin and red cell count, it changes over time in the neonatal and infant period. We should also mention a few words about the anemia of prematurity, right? What we were looking at before was a term infant, but if an infant is premature, we still have a drop in hemoglobin, but 2 things can be different. Number 1, they can start out at a lower level, number 1, and number 2, the drop can be lower. The drop can be greater in magnitude to a lower level. So if you compare term infants to preemies to very tiny preemies, the magnitude of the anemia can be greater and the magnitude of the drop can be greater. And there's lots to say about the anemia of prematurity. That's its own big subject, but a few highlights include that one thing I'm concerned about is phlebotomy red cell losses, right? Or lab draws, drawing blood for labs for the patient. We should try to minimize that so that we don't make the patient anemic even further with all these lab tests. And in fact, in many surveys, the most common reason that a preemie needs a blood transfusion is because of phlebotomy losses, iatrogenic blood loss from taking a bunch of labs. So, big picture, there's conflicting data about outcomes from having a restrictive strategy for transfusion versus a more liberal strategy, trying to transfuse to a higher hemoglobin. So I can't really tell you to the degree that we can, like for adults, this is a good or worse indication for transfusion for a neonate. But I can say with some certainty we want to minimize iatrogenic blood loss, especially for blood gases, things that will require a relatively large volume for the instrument to do the test. So one list of indications, again, this is not definitive, but different experts have different opinions about the indications. But for red cell transfusions, specifically for the anemia of prematurity, it really depends on how is the patient doing. How is the patient doing from a cardiopulmonary point of view? So they want to maintain a high hematocrit in the 40s for severe cardiopulmonary disease, in the 30s if it's kind of moderate, and then ditto in the 30s for major surgery. And then they could go down as low as to the 20s if the infant is stable but has unexplained breathing, tachycardia, poor growth, things like that. So it's kind of a different world from what we see in adults. And we do things a little bit differently in the blood bank. We don't do ABL back typing, right? Because we don't expect the baby to make antibodies for ABL purposes or antibodies for any reason until about 4 to 6 months of age. So there's no point doing back typing looking for anti-A and anti-B. And if the mom or the baby's antibody screen is positive, we're going to use maternal plasma for any red blood cell cross matches. And what we generally do is we'll use one unit over and over because we try to minimize donor exposures, right? We don't need to give an entire unit typically for a standard transfusion to a neonate, so we'll give a small aliquot off the unit and just reuse it over and over. I'll talk about that in more detail in a few minutes and show you some pictures of that. A typical dose is weight-based and is somewhere in the neighborhood of 10 to 15 mLs per kilogram. That 10 to 15 I use for all blood products as a dose. 10 to 15 mLs per kilogram of red cells, platelets, plasma, or cryoprecipitate. And it's also worth mentioning that, as we talked about before in our blood processing questions, that an additive solution like Adzol and so on usually has a hematocrit of about 60, somewhere in the 55 to 65 range. And you might see some units that are stored in CPDA1, the hematocrit is higher, or the so-called packed cells, whereas nowadays nearly everything is an additive solution and it's not really packed that much. It's somewhere in the 50s to low 60s. And then one additive solution in particular is AS3. This is popular and one you should know about because it lacks mannitol. AS3 lacks mannitol. Neonatologists like that because it's not introducing any extraneous diuretics into the patient. And as I mentioned before, we could use a syringe from the bag and issue that from the blood bank, or an aliquot. And to summarize a lot of nuance, in general, there's no really good data that shows that when you have a CMV seronegative donor, in addition to a leukoreduced unit, that combination will decrease the risk of CMV transmission. So at best, it was a theoretical benefit. I say was because there's been recent data in the last 10 or 15 years that it looks like CMV seronegative donors actually have a higher risk of CMV transmission compared to CMV positive or CMV untested. And you might say, that's nuts, what's going on with that? Well, what appears to be happening is that antibodies are protective. That if you have CMV seropositivity, that these antibodies can be protective. So again, we're not testing for CMV, the virus, the virions, we're testing for the antibodies. So another way to say the same thing is it looks like that you could have basically two ways of having a CMV transmission. One way is it's a CMV seronegative donor and there's a window period infection, right? And the other way is that you have a CMV seropositive donor that was infected in the past that is now reinfected, right? So what they found is that it looks like, while both of those are very rare, that the CMV window period infection is significantly more common than the reinfection or reactivation. So lots to say about that, but the more practical point is it's becoming less and less popular to ask for units from CMV seronegative donors. So on the one hand, there's no strong data that that's helpful, and there appears to be decent data that the transmission of CMV is actually higher in CMV seronegative units. So lots to say. The highest yield factoid is that leukoreduced units, the risk of CMV transmission is in the neighborhood of about 1%. That is not controversial and that is relatively unchanged. And then we'll often see irradiation based on the patient age. So for preemies, low birth weight infants, and even for Otherwise, beyond those three instances, there's not really one clear consensus. At some hospitals, they say they will irradiate or they'll allow irradiation if the patient is less than a month old. Other hospitals say less than 4 months or less than 6 months, all the way up to 12 months. And that's a kind of a permissive, yeah, we'll do it if you ask for it. And then other hospitals say it's required. Like they will irradiate the red cells or the platelets even if they don't ask for it. So there's a wide variety of practices about irradiating for neonates outside of prematurity. And so, unlike with bigger people, platelets should generally be ABO compatible. Ideally, they don't have to be. I mean, big picture, if you're an adult, if you're a big kid, any recipient can get any ABO type of platelet, but we have what I call preferences, not requirements. We'll usually have a preference that it's ABO identical, and then we'll go through the list of other ABOs based on relative major incompatibility, right? But it's slightly different for neonates in that, again, this is not universal, but there's a tendency to want to avoid type O platelets because O donors can often have a high titer of anti-A, and that tends to be higher even than their anti-B. And we want to avoid giving O platelets to type A, especially type A infants, and to some degree type B, but mainly type A, because that anti-A can be a very high titer. If all you have is O platelets, then you could always volume reduce or remove some plasma from the unit of platelets if you have time. A lot of this has been rendered moot by pathogen reduced or PAS platelets that essentially remove a large quantity of the plasma anyway. So it depends on your platelet product. Mamas and babies, okay, HDN. I'm not going to spend a heck of a lot of time on the pathophysiology because I think you already know this by now. But very briefly, as a reminder, it could be for any antigen that can lead to a clinically significant antibody. But in this case, let's say the D antigen, she's negative for that. And let's say the fetus is positive for that antigen. Then what could happen is there can be some degree of an interface between fetal circulation and maternal circulation. And so mom is exposed to the D antigen, she can make antibodies. Most generally, that does not affect the first pregnancy if it's outside the ABO system. And when mom makes anti-D antibodies in a subsequent pregnancy, assuming, of course, the next fetus is also D positive, that can affect that pregnancy. Mom's anti-D can start to recognize the D antigen in fetal circulation and start to destroy fetal red cells and cause fetal anemia or worse. So a few factoids that are worth remembering. If the question is what's the most common cause of HDN overall, it's the ABO incompatibility, meaning mom is type O and fetus is not O. So some IgGs can pass through the placenta and affect fetus. Luckily, at worst, that's a mild hemolytic disease of the newborn, hemolytic disease of the fetus, and it does not typically require an intrauterine transfusion. If the question is, however, what's the most common cause of severe hemolytic disease of the fetus newborn, meaning severe would be something that would require an intrauterine transfusion, that's anti-D, anti-big K, and anti-little c. Those are typically the most common ones. And it's worth remembering that RhoGAM, giving mom a shot of anti-D to somehow prevent anti-D formation through unclear mechanisms, that has decreased the incidence of anti-D formation to less than 0.1%. But also remember that RhoGAM only prevents anti-D. We don't have in common practice similar antibodies we can give mom that would prevent the formation of other antibodies like anti-big K, anti-little c, and so on. At least not in this country. So RhoGAM, so all the details about RhoGAM are very high yield, very worth knowing about. So when should you give rogaine? So you should give it to a mom who's eligible. So a mom that's D negative and she has not yet made anti-D, right? She's already made it. The horse is out of the barn. There's no point trying to prevent it. So we would give it to her at 28 weeks of pregnancy and also at delivery if it applies, if the baby is D positive. And of course, with any risk of fetal maternal hemorrhage during pregnancy. So at delivery, if baby is D positive or if baby is weak D as well. Ideally, you would want to give rogaine within 72 hours of delivery. Otherwise, give it as soon as possible. It's actually been shown to help up to 28 days postpartum. So if you miss that window, it's worse, but it's still useful to give it with up to 28 days. And you don't have to give rogaine if you have given it 3 weeks before birth. So let's say she had a procedure done, or for some other reason she got rogaine 2 weeks ago, and then she delivered today. She doesn't need to get an additional rogaine today, assuming there are no other complications. And how do you dose rogaine? This is also high yield. Rogaine is a high yield subject. So if you have a D positive baby and a D negative mom who's not yet made anti-D, you want to always give at least 1 vial. So if that first part is true, you're going to give at least 1 vial. I can't think of a circumstance when you'd give 0 unless you had just recently received it. So all the calculations that we're going to talk about have to do with, do we give 1 or more than 1, okay? The calculation is not, should we give it or not? The calculation is, we're going to give it, but is it going to be 1 or more than 1? We would give 1 vial if the Rosette test is negative, right? So there's not a significant amount of D positive red cells in maternal circulation. That's what the Rosette test tells us. And we also would give 1 if we do a quantitative measurement for fetal red cells in maternal circulation for hemoglobin F. So if we find no hemoglobin F by either the Kleihauer-Betke, which we'll talk about in a second, or flow cytometry looking for hemoglobin F, if we have 0%, we'll still give 1, okay? We'll still give 1. Don't let that confuse you. If somebody asks you, well, the Kleihauer-Betke found 0% fetal red cells in maternal circulation, how many vials of rogaine should we give? They always are trying to tempt you to say 0 because, well, 0 must lead to 0. No, we're always going to give at least 1 vial. The shortcut I use, and I would use it, let's say, on the rotation exam, because this is nearly always the way to do it, is we want to use 5/3 times the percentage of fetal red cells in maternal circulation. So we would use a percent, round it, and then add 1. Add 1 for safety. So one example, we would use a percentage, not a decimal, right? So 2%, we would use 2, not 0.02. So 2%, so 2 times 5/3 would be 10 over 3, or 3.3. We round that to 3, add 1, and then that's 4 vials. Some books say some nonsense like, well, if it's 0.4 or 4.9 or less, then round down. If it's 0.5 or higher, then round up. I don't know why they add all this verbosity and complexity. They're just describing the process of rounding, and I think you learn how to round at some point in grade school. So just round like you would in 5th grade or whatever, and then add 1. So even if you can't remember what we just talked about on the first slide, always use the calculation, because even if the number is 0, you'll still get the right answer. So let's say 0% from the Kleihauer-Betke. So it'd be 5/3 times 0, which is 0. We round that, it stays 0, and then we add 1, so we get the answer of 1. So we still get the right answer. We still give 1, even if the percent fetal red cells is 0 in an eligible mother. So this is my editorial, you do what you want, you're a grown person, but don't get involved in paternal testing as a means to try to prevent giving rogaine to mom. It's a shot, it's unpleasant, but mistaking that dude for the dad when in fact the fetus has a different father and is in fact D positive and you didn't give rogaine, and then mom develops anti-D. You know what I'm saying? You don't want to deal with that. So this is all cute in theoretical terms, but not really. Don't do it. Don't get into some Maury Povich nonsense. Okay. How do we manage hemolytic disease of the fetus newborn? So if we weren't able to prevent it using rogaine, or if it's a different specificity, how do we manage it once it happens, once mom is alloimmunized? So we would do one thing. We would do an antibody screen to try to detect this at the first prenatal visit. So an antibody screen at the first prenatal visit is the typical recommendation. And if we find a clinically significant antibody, then we want to follow the titers every 4 weeks after 18 weeks. The main reason we want to start at 18 weeks is because the main test for fetal anemia, the MCA Doppler, which we'll talk about in a second, is really only validated after 18 weeks, somewhere in the 18 to 36 weeks range. So what is the titer? The titer is just the reciprocal of the most diluted 1+ reaction. So we will gradually dilute the plasma from mom. We'll dilute it 1 to 2, and then 1 to 4, and then 1 to 8, 1 to 16, 1 to 32, and so on. So the 1 to 2 and the 1 to 4, etc., is the dilution. That's not the titer. The titer is the reciprocal, so that's going to be, for example, 16 or 8. That's the titer of the most diluted 1+ reaction. So ignore the negatives and ignore the weak plus. If it's a 1+ or greater, the most diluted dilution, you take the reciprocal, that's the titer. You don't need to do this if it's a KEL antibody. Why is that? Because remember, KEL antigens are on red cell precursors, right? On red cell precursors. So even a little bit of anti-big K antigen can cause a severe fetal anemia. So you don't need to sit and wait until there's a high enough titer. Any amount is bad. And you also don't need to do this titer stuff typically if there's been a previously affected pregnancy with this antibody, right? Because it's usually the antibody titer is so great, and it's also unpredictable how the titer will correlate with fetal anemia. And generally we like to do titers in the same lab and in parallel because the endpoint is just 1+ red cell agglutination as opposed to weak plus. And so there's a lot of subjectivity in making that call. And once we reach the critical titer, and that's locally defined, right? There's not one critical titer for all times and places. Because of all the subjectivity in determining the titer, there's usually a locally defined titer, and it's often somewhere in the range of 8 or 16 to 32. These are some common critical titers. Once you reach that, then you do middle cerebral artery Doppler, right? And we'll talk about that in a second. The main purpose of that, this is the most common test to look for fetal anemia, okay? So we reached our critical titer. Now we're going to do the MCA Doppler to look for fetal anemia. So what's going on? The main principle here is, here's our circle of Willis. What are you talking about, Willis? And we're looking at the middle cerebral artery. And what they've been able to do is they've been able to correlate the peak, this is the PS, peak systolic velocity of blood through that artery with fetal anemia. So in simple terms, the faster that velocity, the fewer red cells there are. So the more anemic the patient is. So the higher the velocity, the fewer the red cells, so the more anemic the patient is. So now you have a peak systolic velocity. What do you do with that? So we have our middle cerebral artery peak systolic velocity. The benefit of this is it correlates with anemia at 18 to 36 weeks, as we mentioned. And if we adjust for gestational age here on the x-axis, from 18 to about 36, and on the y-axis is our MCA peak systolic velocity. The main thing to remember is that adjusted for gestational age, if you reach 1.5 multiples of the median, 1.5 multiples of the median, it's got a big red arrow, it must be important. That is the signal to do an intrauterine transfusion, okay? So what is that telling us? That's telling us that if the velocity is fast enough, that means the fetus is anemic enough that an intrauterine transfusion is worth it, is worth the risks of doing it. And what will we do for an intrauterine transfusion? We'll give type O, usually D negative, but it doesn't have to be. Don't freak out, we'll talk about that in a second. It will irradiate it, right, of course. Usually it's common practice to get sickle negative donors, like a donor that's not sickle trait positive. That's a common thing to do, just to err on the side of we don't want to introduce any irreversibly sickled cells to these really small vessel fetuses, right? Plus or minus CMV seronegative, we already talked about that. I would say now we don't have to deal with that. As long as it's liquid reduced, I'm happy. CMV seronegative is, I suspect, a thing of the past. Don't yell at me if you disagree. And I should mention, and it's in red print, right? So this must be important, that the key principle is we want this unit for intrauterine transfusion to be antigen negative for the targets of the maternal antibodies. That sounds basic and simple, but you'll be surprised how quickly people get confused. Another way to say it is that it has to be cross-match compatible with maternal plasma. This starts to become a little hairy if mom has an anti-little c or an anti-little e. That means we have to give D positive. We have to give D positive units for intrauterine transfusion. We'll talk more about that in detail, person to person. But just to be provocative, it is okay if mom has anti-little c or anti-little e if she gets D positive units for an intrauterine transfusion. That's actually optimal. Exactly. So speaking of different phenotypes, we're going to talk about neonatal alloimmune thrombocytopenia. The way I think about this condition is it's kind of like platelet HDN, like the platelet version of HDN. So there's some similarities, and then we'll talk about some key differences. It's usually due to an antibody against the HPA-1A antigen, or the human platelet antigen 1A, meaning mom is usually homozygous for 1B, which is relatively rare to be homozygous for 1B. And it's the same kind of pathophysiology. The fetus is positive for HPA-1A, and then mom makes antibodies to that 1A antigen. It's different from HDN as this can affect the first pregnancy, right? Severe HDN doesn't typically affect the first pregnancy, but NAIT can affect the first pregnancy. In many cases, the platelet count of the fetus can be severely low, usually less than 20, so it can be quite dramatic. The main thing we're worried about is intracranial hemorrhage risk, right? Because you gotta think about it, I have a hard head, but when you're a fetus and when you're a neonate, you don't have a hard head yet, right? So the brain is most at risk for bleeding in the setting of a severe thrombocytopenia. And so what is one of the main treatments? That is to give antigen negative platelets. So that can very possibly be from a blood donor that is known to be negative for 1A and is homozygous for 1B. But if you're unable to find a donor that is negative for HPA-1A, you could sometimes, if mom is eligible to donate and well enough, if I should say otherwise eligible to donate, because we could bypass that whole rule about you can't donate 6 weeks after delivering. Setting that aside, we can use mom's platelets, right? So we could use mom's platelets because why? She's 1A negative, right? She makes the alloantibody, so she's 1A negative, that's good. But we would want to wash the platelets, right? We would want to wash the platelets, assuming it wasn't a PAS platelet that has very little plasma in it. We would wash the platelets because we want to get rid of this antibody. There's no point transfusing more antibody that will affect fetal antigens on platelets, right? We don't want to do that. So maternal washed, and of course irradiated because it's a neonate. Maternal washed irradiated platelets. That's a common PIP question that you get. What's one of the common treatments for NAIT? Maternal washed irradiated platelets. But the main concept is we're trying to avoid this antigen, And we're also trying to avoid infusing additional antibody, hence the washing. Clear as mud? All right. And then finally, PTP, post-transfusion purpura. You may ask, why is this in the mamas and babies talk? Anybody could get PTP, yes, but it tends to be overrepresented in postpartum women. It tends to be overrepresented in postpartum women, number one. And number two, there's some commonalities between the serology of PTP and NAIT, which we'll talk about. I kind of think of this as, in some ways, like a delayed thrombocytopenic transfusion reaction. And I guess an even closer analogy would be to hyperhemolysis syndrome, right? We talked about hyperhemolysis syndrome can be when, let's say, a sickle cell patient has an alloantibody to a red cell antigen, and then they have a red cell transfusion, then they have a delayed hemolytic transfusion reaction that snowballs into what appears to be an autoimmune process, or in any case, their own red cells start to be destroyed for unclear reasons. And that's a hyperhemolysis syndrome. This is kind of like a hyperplatelet destruction syndrome in some ways. So it starts similarly, which is that the patient has usually an alloantibody to the 1A antigen. There could be others, but that's a common one. And this may seem weird, but it does make sense if you think through it. This is usually caused by a red cell transfusion. And you're like, what is happening? How could a red cell transfusion have HPA-1A anywhere near that? Do red cells have HPAs on them? No, they don't. But in a typical bag of red cells, we go straight to a hard spin, and we don't separate the platelets from the red cells when someone donates whole blood. And so when somebody donates whole blood, we go straight to the hard spin, and there are platelets admixed with the red cells, right? So these platelets, even though they may be long dead, weeks into storage, they're still to some degree immunologically active, meaning they could be detected by the patient, and the patient can mount an immunologic response against them. So in short, there could be dead pieces of platelets and platelet antigens in the red cell product. So don't let that confuse you if you get pimped about that. And then what happens? About 2 to 14 days later, you see a patient with low platelets, and platelets even lower than their baseline, right? And they may have some bleeding. There's unfortunately about a 10% mortality and a 30% major hemorrhage, and a common treatment is with IVIG. Okay, we are done for now. Remember to do the quiz questions, and we'll chat person to person about kind of the nuances of intrauterine transfusions.